going to be a general inquiries. So if you've been watching our videos or you've just been practicing scanning and you have any burning questions that you'd like us to run through, then this is the opportunity for that. Otherwise, we thought we'd just break the ice and just get started scanning. So I think the first module that was done was the elbow. So I think Adrian's happy to just start scanning and going over it. Hopefully that gets us all warmed up and questions start coming in and we start flowing. Otherwise, we'll just carry on looking maybe at the shoulder next and then the knee and see how we go. So over to you, Adrian. Would you like my elbow?
Yeah, we can do that.
So were there any key points that you just want to go over from those modules that you did of elbows? We did a series of 4, was it, for the elbow?
Yeah, so sort of anterior, posterior, medial, and lateral, I guess.
Yeah.
I think those are the ones that we did. We broke them down into that. Not too difficult. It gets a little bit difficult when you're looking at the distal biceps tendon. That can be quite challenging for some people. But other than that, it's pretty straightforward exams to look at with the elbow.
Any more common injuries than others that you tend to see more of?
I think the most common one is probably your lateral epicondylosis, your tennis elbow. That's what we tend to see most of, or I tend to see most of. Don't get that many elbows come through, to be honest, and if they do, they tend to be mainly those. Get an occasional, just looking for foreign bodies or fusions or olecranon bursitis, things like that. But it tends to be, if it's an elbow, it tends to be sort of lateral elbow pain, lateral epicondylosis, and tennis elbow, and things like that.
Should we maybe start looking at those? It's quite common this time of year, isn't it?
Yeah.
COVID, a lot more racket sports, so tennis and golf as elbows maybe.
Yeah.
A bit more common.
So I tend to get the arm in this sort of position, and I
just adjust the camera here.
And I finally sort of lateral epicondyle, and I just drop that straight down onto it there. And this is sort of your this is your sort of pretty picture, as it were. There, and actually just remember your depth and your focus is all in it right. That's a good image there. And you've got the okay.
I was just trying to give him a better picture. How's that picture of elbow Adrian's probe position on the elbow there? Do you think you can see what you need to there? Or do you want us to?
Yeah, I think that's pretty good.
See where we are roughly.
So you can go up.
I was on mute then. Yeah, we've got a good shot of that. Thanks, Abid.
Good. And then you can see how my probe is not directly perpendicular or not typically horizontal. It's pretty straight down in a diagonal fashion. So it's sort of perpendicular to this part of the elbow, if you like. Okay. And then I come and find the lateral epicondylar, and actually sort of a pretty picture for your lateral epicondylar, but you really want to interrogate the ECRB, which is maybe most where it tends to happen. It just tends to just move slightly upwards until you lose that bony contour there. So you just on this lateral elbow here. And if you put the colour on, I tend to just put that across there. So I'm going to change that to PDI and just basically interrogate that area just there, looking for any tears or any flow within that there. And that should be pretty much on the ERCB. And as you come down, move down the elbow, then come to this structure here, which will be your lateral collateral ligaments.
What features would you expect to see to help confirm your diagnosis? Are you going to get calipers out at this point at all?
So if you saw a tear here, you just sort of measure the tear in a long section. in two planes, and you could turn transverse and measure it in that plane as well. Okay.
Will you always see it in both planes?
You will always see it in both planes if it's there. If you don't see it in both planes, then you should just sort of question it. Is that really there? Is that artifact? So you should see it in both planes. Okay, then put the Doppler on. And what you tend to have is a little anechoic defect here. You might get a little bit of cortical irregularity. It might be a bit of avulsion injury with the bone sort of slipping up here. You can see that. And then if you put the Doppler on, just remember when you do put the Doppler on, just to have a lightest touch as possible. And that will give you the best chance of seeing your Doppler signal. So if you add pressure, too much pressure, you'll compress the vessels.
And it's not necessarily a lot of pressure there, is it? Because it's quite a superficial structure. It's quite easy.
Yeah,
to
no, exactly. And if you want to test that, then I suggest you get a big stand-up of gel. Okay, rest your probe on there, and as you release the pressure, you should get a real sense for a little bit of a standoff gel at the top here, and then you really know that haven't got so much pressure. Okay.
So a nice layer of jelly should be quite easy to see.
Yeah.
At the top of the picture before you get to the skin.
Yeah.
And
now this is it's quite difficult to get all those factors right here because of this. So if I was doing this in the hospital, I'd get the patient opposite, and I'd get them to put their arm relaxed on the table like that, and then I'd be able to just steady my hand on the elbow. It's a little bit difficult here, but just doing it just to show you. So always change the position of your patient when you're scanning. That gives you the best option to get the best technique out of your scan. Whether you need to add less pressure or in a position where you're not in so much of a position where it's going to cause you any musculoskeletal problems as well. Because if you're doing this all day as well, they soon add up.
nice question there. I can see
Yeah,
do you
thanks,
report
Abid.
percentage in partial thickness tears? Would that be useful from Probably.
I don't personally. I bet there may be some people that do. I would probably just give the measurement. It's quite difficult to do it as a percentage because there's no clearly defined area. I mean, some of this will be collateral ligament, so it's a bit difficult. So I think depending on what you see and how much is ligament and how much is tendon, it's quite difficult to interrogate or interpret that. So I would probably just tend to measure it. I know that right down at the bottom here, that's going to be ligament, because you can see the ligament there. So that much is ligament to about here. So if it's 50%, it's going to be sort of up here somewhere with the ligament down here. But I mean, I don't tend to report the percentage really, but just give the measurement.
Interrogating the joint margin while you're there? Or
yeah, absolutely.
Yeah,
look at obviously the joints, any effusion, the irregularity. Yes.
So measure the joint space itself.
Yes. So I probably measure it. I don't have any fixed numbers for this, but I would probably compare it with the other side, and obviously get the same position and compare it with the other side. If there's any difference, then I'd say that.
Just practically saying what you see.
Yeah, exactly.
It's very individual things. So.
Yeah. So anything else? No. Okay. Well, let's have a look at something else. Maybe the biceps tendon. So here you can see the central portion of the tendon of the biceps. Okay. So if you follow that down, all this is going to join to form tendon. Okay. Now it's quite difficult to follow this down in transverse. You've got to keep angling and keep angling. It's dipping quite sharply now, you see, so I'm losing it here. And of course, it's on the radial tuberosity inside, so if I come to the side and dig in slightly, then I can do it that way. Coming down here, it's probably feeling that.
Yeah, a bit tender there.
Yeah. So, and then it inserts here. But you can come in from the side, slightly bent. Right there, and interrogate it. Yeah, that way onto the radial tuberosity. And what I found is if you follow the median nerve, which is here, okay, and you follow it until it reaches the bottom here, and this is the tuberosity here. So therefore, I just rotate around that area and we give it the right depth. Right, rotate round, so I'm going out to the medial side and then turn long section. And there you are. And that brings you right onto it then. And this will be the long short head, and then the long head slightly inferior to that. There. Yeah. And finally, you'll find it easy on someone and then not on another. So it's just a matter of playing around with your technique until you find it. Okay. You can see that nicely inserted there. Okay. If you go transverse, you can sometimes see both of them together. Get a nice soft speed. These two down here, but I'm losing it now. So come down. So this is the median nerve. Down to the bottom, and then this is the radial tuberosity. So I go around into the medial aspect and then angle back up. This is down here. So then I write onto the depth and take the focus down. All that helps. Looking on that inserting nicely there. So I find that's quite useful with the median nerve. So this is the pronator teres here. It comes down. And when it reaches the bottom underneath the pronator teres, this is the radial tuberosity. And then you just rotate around, angle up, and there you go. There's your biceps tendon. Okay.
Lovely.
So any more questions?
There's
Okay.
not. Excuse me. There's not. But thank you for that. That's a good little insight into the elbow. Thank you.
Anybody like anything covering next? Otherwise, we'll maybe just go to the shoulder, perhaps.
Yeah.
Or do you want to
Yeah.
do a bit of foot for the pods out there?
Yeah, if you've got something lower limb, we've got a good number of our pods with us this evening. So if you've got anything knee
Yeah.
or ankle, would be good. And Olga's got a question. Of course you can, Olga. Please do. Do you want me to unmute you?
Hi, sorry.
Hey, here you go.
Yeah, it's Kathy. Hi, everybody.
Hi, Olga.
Hello, Olga.
Hi, I've got a question with regards to gastrocnemius and soleus muscle group, and when we look to explore the region for some scarring following old injuries. So when you're assessing that musculature and the fibers, there will be an amount of normal thickening because of the activity levels and the scarring.
Yeah.
So making that differentiation between fibrous fibers, muscle fibers versus scarred fibers, what would your go-to process be?
Well, one, you have to be really careful with Soleus ultrasound. MRI is the best. I mean, you can look at Soleus if you've had a lot of experience and practice with it, but it is quite difficult. I think we can only pick up like 30% of Soleus tears and things like that on ultrasound. But essentially, scarring. So there's your gastrocs here. Okay, so there's your medial, and there's your lateral, and this is Soleus. So you can see how that, because of the architecture, it's really difficult to pick up anything significant here. But scarring tends to be sort of focal hyperechoic thickening areas. So you may see these bands, fibers extra thick. So you can look at it that way. I think the best way to look at this Soleus is to come round the muscle belly and interrogate and try and get the fibers perpendicular to your probe to interrogate them. So if you come to the side here and then look along here, along these fibers, and just look for any sort of focal, thickened areas to the muscle architecture. See, I mean, this is the sort of thing you're looking for. So, like a big thickened area here. And then you can put the Doppler on, and if there's any sort of activity on there, you can get sort of reactivation of these scarred areas. So just to interrogate that as well with the Doppler. But yeah, just do be careful with Soleus. Looking at Soleus really, because it can be tricky. And the same with gastroc, really, just looking for focal irregular thickenings of hyperexicity for previous scarred areas. I think that's what you're asking. If you turn long section, you can see these fibers are nice.
Yeah, it's knowing how much of it is too much, really, because when it comes to some of the injection therapy, having like hydra almost lysis applied to it with a sterile saline, is which fiber you would address, what is classed too thickened to go for, if that makes sense. Or would you correlate it purely to the site of pain?
Yeah, I don't have any specific measurement that I would do to say, oh, well, that's definitely a scarred area. I would just look at the architecture of the muscle fibers, and if it's looking straight and then suddenly goes totally thickened,
yeah,
then I'd be more inclined to think, okay, that's maybe a bit of scarring there. And another good tip is to, if you run through the muscle quite quickly, then focal areas will jump out at you. So if you're running through it quite quickly, then and you come across a scarred area, a little nodule will pop out quicker, but easier for you than if you're just going through it slowly. So you can do this to start with, just to get your eye in, and then interrogate it a bit more if you see something jump out at you. That's what I'd do. But
that's brilliant. Thank you.
Thank you, Olga. So yeah, Adrian, the questions are now coming in thick and fast, but maybe we could just a request from David on the neuromas, if we could do that next, please.
Oh yes. Okay.
Yeah,
And then I'll come to the other questions that just come in.
Yeah, thank you.
So, I mean, there are some people that look for neuromas dorsally. I don't tend to, but you can look dorsally. And if you've got like a hockey stick probe, then actually dorsally is quite good, because you can get in between the toes and interrogate them a lot easier you can with a more wider probe. So if I've only got this, then I tend to look plantally. Then what I do is I get the patient to relax the foot as much as possible, because they tense up, and it's quite difficult to interrogate then. I know automatically with the normal setting that it's going to be too dark, so you can see my screen's too dark. So I always go up on the gain, increase the gain, and I go down on the frequency. Okay, and I get the right depth. So that's what I do at the start of every single new when I'm looking for neuroma.
Adrian, what sort of frequency?
So this is on about 6 to 10.
Okay, thank you.
So I think the one I use at the hospital goes down to about 9, and I tend to whack it down to 9, and that tends to be ideal.
Where do you prefer your focus?
So where I'm expecting to see the neuroma, really. So I come across into the space, then I'm roughly expecting it to be where that right across where that focus is actually.
And you're in long axis there, so you're just scanning over the.
So in long axis, I'm looking at the net head here, and then basically I use three fingers or my thumb. So if you use one finger, it tends to be quite painful, and so you might get false positives with the pain. So I tend to use the pad of 3 fingers or my thumb, and just in between the toes. Okay, and I get to the met head, and then basically I just angle into the space and compress. Okay, and there's nothing in there I can see. And you can see a bit of the nerve going across there.
There's nothing in there. That's pretty painful. That's pretty sore to.
Is it? Was that kind? Yeah. So
some neuromas are pretty angry, aren't they? So it's a bit.
Yeah.
So sometimes there's
so
lots
this is
of
the nerve
things
coming
going.
through. Yeah. So not seeing anything in that one, and then I also look transverse as well. So I do both, and I push up, and I can see I'm pushing the right one because I can see that movement at the bottom. Okay, and you can use my thumb. There's really nothing. It's all bright in the middle. Not seeing anything, and I may even do little moulders as well to see if anything pops up. And I do that to all of them. So I go to the next one, angle into the space, push. Nothing there. You can see the bit of the nerve going along there. You can see it how it jumps.
So you're sort of looking for like an effusion to come through between the mets type of thing.
So no, I'm looking for the jump in the neuroma. I mean, they tend to be a complex. So they tend to be a bursal neuroma complex. So you may get a little bit of fluid as well.
Right.
So, but when you squeeze and you'll see a dark blob, and it will pop. I mean, it's up on the screen, but it's actually down on the.
Yeah, I understand.
Yeah.
Okay.
So,
Adrian, have you got Zoe speaking? Have you got the gain turned right up to assess the forefoot? Is that
I have. Yeah.
Is that a better option just for assessing those sort of darker areas?
Yeah, because if you have it too dark, then it's really difficult to say, well, is that more bursal? Is that more neuroma? Is that, what is that? So if you turn the gain up, not too much, but enough so it defines your borders quite well. So you can see there's no dark hypoechoic area in there at all. Okay, so if I turn the gain down, and I do the same thing, yeah, it's still pretty convincing. But I prefer it just a little bit.
You see the nerve going through. You've got
Yeah.
axis now, haven't you?
Yeah, so I'm very happy there's no neuroma there at all. And then into transverse, again, squeeze, do moulders, nothing. I do that along as well.
I've got another question from Sandra, which we'll come to, but Zoe, are you still there?
Thanks, Adrian.
That's
Thanks,
okay,
David.
you're welcome.
I wasn't sure if Zoe's there because Zoe has asked a
Yeah, I'm
question,
here.
but yeah. Do you want to ask your question now while you're there?
Yeah, so basically, I'm doing my mentoring at the moment. It's all going really well, apart from I just want some clarification on medial
I can't hear it, sorry.
assessing the retinaculum and the tibial nerve, and been able to chase the tibial nerve down a little bit as well. just if we're assessing like tarsal tunnel or, you know.
You might have to repeat that, Steve. I can't hear that.
Okay, I think Zoe's asking the medial ankle structures, in particular the retinaculum, which I can never say, tibial nerve, and chasing it down into the medial ankle foot. Just like a bit of a revision or support on that one. Lateral ankle ligaments too, please, and perineals.
Just a comment on the neuroma thing. I think maybe if Adrian agrees, always good practice to just do a full forefoot examination rather than just look for one specific condition. It's good practice to get into, I think. So just assess your MTPs and plant plates at the same time.
Thank you.
Okay, so here's
Thanks,
you're welcome. So here's the medial. There's your tib post, digitorum. Lucis. Okay, and there's your neurovascular bundle. Now I don't know how far. I mean, I'll trace it down into the tunnel, but unless they're specifically looking, I won't trace it to the sort of medial calcaneum or unless I see anything really or specifically looking. I just tend to go down to the tunnel and just interrogate that area, and you can see them splitting off here anyway. So that's what I tend to how I tend to look at it. So there's your nerve. A little bit too much more there. And I just basically look for any sort of compressive neuropathy within the tunnel, any ganglion cysts or anything like that. Follow the nerve as far as I can. It's difficult to look for really tiny things when you go any further than that. Long section. Just see how the caliber of the nerve changes, if it does at all. Does that help at all? Is that what you're after?
I'll wait to see if we get this thumbs up from Zoe. Thank you, Zoe, as always. Glad you could join us. I did have a question here from Sandra. Here we go. Sandra, sorry, had you completed that then? Sorry.
Yeah, no, I'm just carrying on following the nerve.
Sorry, I'll check in with Zoe that she's happy with that. We can always come back to it. But a question from Sandra, I should say. Sandra says, I have come across cobblestone a few times. Is this always due to cellulitis?
Edema as well.
Yeah, it's just I think the cobblestoning is just like a generic term for the appearance that the edema or whatever is causing that cobblestoning fluid is. I think it's just a generic term for the appearance rather than anything in particular. It's just basically fluid within the superficial tissues, just defining the different sort of globules within the superficial tissues.
More an observation, maybe.
Yeah.
Diagnosis.
Okay.
Yeah, because quite often it gets, if you see it on an MRI, you've got subcutaneous. Quite often it comes back as non-specific subcutaneous swelling.
Yeah.
Just defining what layers it sits in.
Again, if you put the Doppler on that and it's quite vascular, then I'm probably more likely to say, well, that's cellulitis, maybe.
Okay, thank you. Another question coming from Olga, which crossed my mind when you were talking about neuromas there, and you put the gain up. Are there any other pathologies that you would use that kind of technique or trick, for want of a better phrase? Anywhere where you struggle to get your penetration. So I can only think of the neuroma at the moment, but because the skin's quite thick and you
everything's dark, neuromas are inherently dark. So if you turn it too dark, then you're looking at dark next to dark, and it can just be a bit confusing. So if you turn the gain up, it might just define that's definitely dark, and that's not, define your
maybe more in the thickened sort of tissue areas. Another example might be the heel, perhaps.
Yeah.
Often flag the gain up when we're looking at the plantar fascia.
Yeah.
Yeah, because you've got to penetrate through that uppermost layers of this kind of thickened skin tissue there, or subcutaneous fat. Then maybe if you're looking below that layer, you need to work with the gain.
And don't be stuck on just that. I mean, turn it up, turn it down, play around with your settings. Because it's only through manipulating all your settings that you're going to get an idea for what's actually happening on your screen.
Sometimes if there's a tear there, you want to maybe interrogate it. So you're going to play around with your settings, alter your probe angles. Perhaps then you're going to increase and decrease your gain as well, just to see if you can carry on identifying it in the same planes.
Yeah.
Popliteal fossa, do you routinely do that for that as well, or is that not?
Yeah, I can look at that. I'm easy to learn with.
We've had a second to that, so that'd be great.
So, I mean, when you talk about popliteal fossa, I'm thinking like your Baker's cysts and things like that. So, the thing to do is I start a little bit higher up into the thigh, and I'm looking for this structure here. Okay. Okay. So move the depth up a little bit. Oops, the other way. Okay. So I'm looking for this structure here, which is your semitendinosus tendon. Okay, if I go a little bit higher, this is the muscle belly of that. Okay, so semitendinosus and then the semitendinosus muscle. And then as you come down, this sits on this muscle, which is your semimembranosus. Okay, so this is your cherry on the cake. I don't know if anyone's heard that, or your cupcake, and then you've got the cherry on the top. That's how I tend to remember it. So this is my landmark that I start off. Okay, so when I've got that, okay, I follow this down, and you'll see that semimembranosus now is decreasing in size. So it's big muscle here, and it's decreasing in size. This is semitendinosus, and it comes to a tendon here. So this is semimembranosus tendon. There's your semitendinosus, that's your cherry. Okay, this is your semimembranosus. And then if you come across a little bit, you'll see here, which is your medial head of gastroc. Now, if I bring my focus down, that will all sharpen up for you. There you go. Okay. So you're looking for this apex of the medial head of gastroc. And that's the key. Semimembranosus tendon and your medial head of gastroc. So this is your bursa here. So this is where it will come up, and this is your sort of speech bubble. And this is key to diagnosing your Baker's cyst. If you get a big cyst here, you have to see this. You have to see that to call it a Baker's cyst. If you don't see that, then it's a cyst, it's a sarcoma, or whatever. Always look for this speech bubble into this area, and that's your route back into the joint for your Baker's cyst. Just remember they can be quite complex Baker's cysts, so put your Doppler on. You can get some Doppler in your Baker's cyst, but put your Doppler on, as long as it's not florid vascularity. Compress, see how it moves. Obviously, you can get complex Baker's cysts with debris when it's sort of organising, septations, all that. So we're over in the medial fossa here. This is where they arise. So if you're over on the lateral side or in the midline, it's probably not. So here in the midline, we've got obviously the artery and the vein. If I just bend Abid's leg up, you can see that helps. And there's your popliteal vein there. So and you can compress that, make sure that's compressible. Okay, so if you've got a large Baker's cyst, okay, and it's huge, I always tend to try and just interrogate the popliteal vein as well, just to make sure there's no sort of DVT or fundus or anything in there. It's a bit of nerve here. Other things you can look at. So interestingly, if I come down now to the joint, so I'm on the medial aspect of the joint. So this tendon here, this is semimembranosus tendon. So if I curl that now to the medial tibia, you can see that's the semimembranosus tendon. So it's a nice way of interrogating that. I go transverse. There's your landmark for your Baker's cyst, semimembranosus tendon, and there's your space, potential space for the Baker's cyst. Does that answer your question? Hopefully it does.
I'll check in. There is another one. There's got another question or request from Greg. Just to say, question from Sandra. I just realised popped on the screen. It's actually our good friend Chris. Hiya, Chris. Who's I hadn't realised. So our webinars aren't the same without a question from you. So thank you. I'm glad you joined us. So yeah, Greg actually wanted to see the popliteal fossa, so thank you, but also he adds, and any common pathologies. I think that's what you're asking, Greg. So any thoughts on that? Anything you might want to cover and ask?
Well, the common pathologies would be the Baker's cyst. Don't see much else really. I mean, what else did you see? Just tendinopathies, lipomas, lipomas, soft tissue lumps and bumps. Just be careful about interrogating those, but you will get, you might see some, because they come in clearly Baker's cyst because they've got a lump. It could be, it could be a sarcoma, it could be a lipoma, it could be a Baker's cyst, it could be all those sort of things. So just be careful when you are looking, not to just automatically think, oh, this is going to be a Baker's cyst, because it might not be. So just to be aware that there are other things do exist, popliteal aneurysms. Again, put the colour on. If you've got big swirling motion, or lots of flow, then think about your popliteal aneurysm. And obviously it'll be pulsatile. So yeah, so always put your Doppler on anything in the knee, cystic wise, just to keep that option open for you. But other than that, in the back of the knee, not too much. To see, I mean, you can see obviously effusions and foreign bodies, classification, cortical irregularity in the joint, some nice cartilage there. Again, as I say, tendinopathies and things like that.
Okay, thank you. All right, what else have we got?
Lateral ankle.
Yeah, here we go. A lateral ankle, please inclusive of ligament complexes AITFL, ATFL, CFL.
Yeah, that's the point. Yeah, so I tend to dorsiflex. Okay, and it's in this position. It tends to be at the sort of 3 o'clock position if you put your head on the malleolus there. So I'm not so sure that Abid's got an ATFL. Essentially, so this is your this is your fibula, and this is your talus. Fibula, talus. It'd be across here. I don't think.
She's looking for a thin band, about 2 mil.
Yeah, so
thickness
yeah, the
running across.
band would look like sort of this sort of thickness going across. I think you have one, you know.
I don't think I do.
Have you gone over on it?
Yeah, a few times.
Okay. Now from this position, you keep the top of the probe on the fibula. Okay. Now I'm going to put my finger here just to keep it steady. And you rotate until that peak's gone. And the next peak comes. And this is your AITFL. And that might be inferior one. It might be superior one there. Okay. There's a bit of an angle to the AITFL. Yeah, it's there. And then obviously just slightly higher than syndesmosis there. You can put kind of Doppler on there. Yeah. If you angle your probe, you can get it nice and sharp. I'll probably overgain this a little bit there. That's it. ATF, AITF. Yeah.
So you just clock facing, and you've got
Yeah,
trying to fix the point
just
on the
placing.
bit, and then
Yeah,
the 3 should come in the.
that's probably more inferior one. Inferior fascicle as well. Slightly more. Yeah, that's more the AITFL there. There. So it's just clock facing, keeping that probe, this end of the probe still on the fibula, rotating round and then back onto the ATFL here. So it's basically just getting rid of that peak. So it disappears until you see the other one. And you can segregate those. So that's it. That's the and this CFL. So the CFL, yes, the dorsiflex. And basically, I mean, I don't usually have you in this position, but it's a bit awkward, but that's the CFL. So there's the peroneal tendons. These are the peroneal tendons. There's your CFL.
It's like a hammer kick should have been underneath the peroneal.
So you dorsiflex up, and then plantiflex. Flex down. See how it loses tension. And they drop, dorsiflex up, and they springboard up. There's your peroneals there, just there, along with your CFL, where the arrow is. Nice lineage. Does that help?
If you bisect the line between the lateral malleolus and the tip of the posterior facet of the calf, then it's that kind of plane.
So you clock facing really from here. So you've got the CFL going down, then you've got the ATFL, and then the ITFL.
All right. Thank you, chaps.
You use the chroma setting to help visualize different ligament structures. I don't for ligaments, but the chroma setting is really good to use on many different things. I tend to use it on meniscus. That's quite nice to see little meniscal clefts. I use it a lot in gynecology, but because it's just changing that colour of the image, just to something that's not quite always grey, black and white. So the chroma setting is really good if you're looking for real subtle changes.
Thank you, Sandra, otherwise known as Chris. And another request, neurodynamics, please, like peroneal nerve, entrapments around the fibula head, etc. Lots of requests coming in now.
That's quite tricky. Responded to me again. Right, let me see, it might take me a minute or two just to get my bearings here. So this is it here. And it's coming down. Yeah, I'm gonna lose it. So there's the fibula head there. Just the fibula head. So just look at the thickening of that nerve, basically. And it's sometimes an idea to just put that in long section. Just see how the callow rivet changes. Which one definitely want that one. Yeah. So this one's not. It's actually an unusual course. So there it is there. And it goes. Yeah. Minimum reason it goes. In long section, I tend to just see how the colour changes, and it'll be really thickened as it goes round. Yeah. Goes back into the sciatic. Again, following it down. Head. Here it goes. Just switch it as it goes round. Just try and turn it on it. It goes round there. Yeah. So it looks okay. So just look at thread it. It's thick and swollen, hypoechoic. Any cyst around that, compressing on it. Yeah, it's a tricky one. I don't see many of those. But I think the thing to look out for is basically if you get that drop foot, isn't it? You get that sort of drop foot appearance. It's an idea to go and just interrogate the perineal nerve. Does that help?
I will check, of course.
Yeah, thanks.
It does. Brilliant. Thanks, Olga. There was another question or something from Pablo. Would show dynamic evaluation for perineal tendons. Sorry, would show. Is that a question?
Well, see, yeah, I think you show maybe the inverted knee. Yeah. So I think
You're looking for snapping, you know, when we get
Yeah.
that subluxing, perhaps.
yeah, exactly. Yeah. So, can you do that? Yeah, so you can see it moving there. Now I tend to look for it's called the Pac-Man sign. So if the brevis is sort of splitting and sort of engulfing longus, I can tend to see that, and then when you dynamically evaluate, it may suddenly shoot back, or even if it's a split tear, it'll engulf it. But yeah, you can get snapping of that tendon. Just that again for me.
Because it's quite a bony contour as well,
Yeah.
and it is.
So you can see that that's not nothing. It just sort of flicks around the brevis, flicks around the longus. We'll do that around, I suppose.
It's quite obvious to see.
Yeah, yeah, it is. Yeah, that's not doing it. Nice. You can see the brevis muscle. That's the brevis muscle there at the bottom. You can see. Yeah. You've got the CFL just underneath there. You can obviously dynamically test that as well. See how that sort of acts as a sling, trampoline. You can see flex, so push those up a little bit, yeah. So there's lots of sort of dynamic tests you can do just to aid your diagnosis, really, and find out what's going on. Reproduce the clicks that you hear, things like that.
Thank you very much. I think that has covered all the requests that we've had up to this point. Thanks, Pablo. I'm glad we covered that for you. I don't think there's anything outstanding. Conscious of the time as well, coming up to half 10. Gosh,
quite a bit covered there, I think.
Covered a load there. There's been some amazing content as far as I can tell. That's brilliant. I can't, so much covered there. So thank you ever so much. I'll give everybody a chance to ask any more questions. I'll just say a few words, if I may, just whilst we wait to see if there are any last minute questions coming in. But thank you to everybody out there for joining us. If you joined us this evening, you've probably done it through the Eventbrite. And you'd have had the opportunity to follow us on Eventbrite, and that's the best place to see any future events such as these. I'm delighted to say we will be back. What was the date? I know United are playing Atletico Madrid that night. 23rd of Feb. 23rd of Feb. So I might get one of my colleagues to cover. But yeah, 23rd of Feb we are back, and we'll be doing a demonstration. I don't think we've selected a topic yet, chaps. We might do a couple of topics for that. So we'll any requests out there that you'd like us to cover on the 23rd of Feb, we'll have an idea in the next few days, and we'll publish that on Eventbrite. But the date is in the diary, Wednesday the 23rd.
Oh, Steve.
Yeah.
23rd, I'm away skiing.
Are you?
I am.
Okay, well, let's have a look at that. Let's have a look at that. Watch this space, guys, on Eventbrite. We'll check our date. No, don't worry. I'm glad you mentioned it. As a general rule, we'll be looking to do a webinar the third Wednesday of each month. But if we need to switch it around, we'll switch it around. You've done me a favour there. We just won't do it the following week because we'll be playing the away leg. So we'll watch this space, guys. And I think the main message is we will be doing these. We are going to be doing these regularly every month. Typically, we started this year with a Q&A, and we've covered quite a lot. And what we'll do is, moving forward, each webinar we'll pick a topic or a subject, and we'll cover that. And the key advice I can give you here is follow us on Eventbrite, and you'll be up to speed with what we're going to do. And we'll always, whilst the dates will be in the diary, we'll then just keep adding what the topics are as we go along. So you'll get regular updates from Eventbrite if you subscribe to that. So that's the best thing I can recommend. Look out for us on our usual platforms, Facebook, LinkedIn, and all that as well, and you'll get up to speed on that. I'm actually back in a couple of weeks. We are doing a webinar in 2 weeks' time on our laser therapy. We've got 3 of our experts joining us, and then we're going to be having a discussion on the class 4 laser therapy. Maybe you'll join us, Abid, as a laser superstar that you are. So maybe see you there, Abid. But so yeah, so I'm back in 2 weeks' time, but we'll be back again next month. Date to be confirmed. if Adrian comes back with any injuries, then that's what we'll do. That's what we'll do in March if he comes back with any skiing injuries. I'm not wishing it on you, Adrian, but duty calls. So yeah, that's the general message, guys. Thanks ever so much for this evening.
Welcome.
And another thing to mention, on the 2nd of April, so fair warning, on a Saturday, we will be doing a workshop. So we'll be covering
face to face again.
Finally getting face to face again. We'll again watch this space on Eventbrite. We'll be publishing the tickets for that. We are charging for that particular event. Watch this space on Eventbrite. We'll issue the tickets in the next few days. The spaces will go. I'm quite sure that we have to limit the numbers. Although, as I mentioned earlier, maybe if we all bring cheese and wine and say we didn't know we were there, as many of us as possible can turn up, so we can exceed the numbers if we have that excuse. Anyway, I promised we wouldn't touch on politics tonight. So yeah, 2nd of April, one for the diary. If you want more information on that, drop me a line. But look out on Eventbrite, and as I say, I'm quite confident those spaces will go quite quickly. And in the next few weeks, 2 or 3 weeks, we'll issue another date for later in the summer as well. So delighted that we're going to be getting back to doing our actual face-to-face workshops, and we can see these two awesome guys in action even more so than we are doing on webinars.
Yeah, we can't wait. All practical, a little bit of talky, then we're just getting stuck in. And really looking forward to getting back in the classroom, so to speak. Getting some hands-on practical, rather than you watching us on a video.
Yeah, brilliant. And the plan is that there'll be no more than 3 people per scanner, and you'll be scanning all day long. And we're going to focus on the ankle and knee in this first one, but we'll be doing more throughout the summer and so forth. So yeah, really excited about that. So excited I almost forgot. So great, thank you. Let me just double check I've not missed anything. You know what I'm like, I don't like to miss anything. But yeah, thanks from Pablo. You're welcome, Pablo. Thanks for joining us. It was Olga that reminded me of the face-to-face scanning. So yeah, the workshop on the 2nd of April. Thank you all from David. Thanks for joining us, David. Very welcome. Good point, Olga. Very good point. It's in Coventry. We're going to Coventry. Go to the middle of the country, make it nice and easy for as many people as possible. From Sandra, stroke Chris. Thanks again, all of you. Good to see you. Good to see you again, Chris. Thanks for joining us. Thanks for your loyalty and your support of all our webinars. Same to John, actually. John's a regular contributor and joiner of the webinars. Thanks very much, guys. Great evening. Thank you, John. Glad you enjoyed it. Smiley face from Pablo. Great, thank you from Olga. You're very welcome too, Olga. Good to join. Good of you to join us, and thank you for your questions and contribution this evening and keeping the guys on their toes. Brilliant. Otherwise, guys, thank you ever so much. Great to be back. Looking forward to some amazing stuff throughout 2022, and you guys get yourselves home safe. Many thanks again for your hard work and long days, and we will see you soon. I'll speak to you soon, and we will all see you very soon as well. Thank you, everybody out there.
Thanks, everyone.
Grateful.
Thank you. Take care. See you next time.
Now.
Thanks for joining. Good night.
Cheers, guys.
Cheers, Steve.
Thanks, Steve.